In the mid-19th century, European surgery was simultaneously advancing and terrifying. Hospitals had evolved from charitable refugees into structured institutions of discipline, record-keeping, and experimental practice. Surgical instruments gleamed under flickering gaslight, yet antiseptic protocols were primitive and inconsistently applied. Most operations were still performed on conscious patients. Pain was not merely expected, it was considered a critical diagnostic tool. The introduction of ether anesthesia in 1846 in Boston represented a breakthrough, hailed as the end of unmitigated suffering. Yet its adoption in Europe was cautious. German surgeons, particularly in academic centers such as Heidelberg and Berlin, remained skeptical. Ether and chloroform were volatile, sometimes fatal, and the understanding of dosage and patient response was rudimentary. In many hospitals, anesthesia was optional and in some cases discouraged. Contemporary medical texts argued that pain was a vital indicator of life. Only a responsive body could be judged as viable during surgery. A lecture from 1862 declared, "To feel is to know, to endure is to live." The conscious response of the patient is the truest measure of vitality. Within this environment, reconstructive surgery emerged as both a technical challenge and a moral quandary. Industrial accidents, battlefield injuries, and congenital deformities created an urgent need for methods to restore function and form. Yet the tools and techniques available were primitive. Skin flaps, grafts, and facial reconstructions were painstakingly executed, often without anesthesia. Surgeons relied on speed, precision, and the endurance of both patient and operator. Among these practitioners was Dr. Heinrich Moritz Kapp, trained in Heidelberg and Berlin. Kapp's surviving notebooks, preserved in fragments at the Baden State Archive, record operations on miners, laborers, and soldiers. His notes are clinical and detached, precise measurements, suture techniques, and outcomes, with virtually no mention of the patient's distress. Marginal comments by students, however, hint at the human cost. Patient screamed continually. Operation lasted 47 minutes. Doctor remained composed. Kapp's rationale reflected a broader medical philosophy. Pain was interpreted as a signal of life, an instrument by which the surgeon gauged the limits of the human body. To dull or suppress it was to risk obscuring complications such as hemorrhage or shock. Contemporaneous surgical journals note, "Many surgeons believe the operation is best carried out without any form of anesthesia." This was particularly true for delicate reconstructive procedures, jaw repairs, scalp reattachments, and skin grafts, where patient responsiveness was considered essential to success. Antisepsis, introduced by Joseph Lister in the 1860s, began to reduce mortality from infection, but did nothing to alleviate suffering. Reports from German hospitals in the 1880s describe patients dying under chloroform masks or ether vapors, reinforcing the belief that conscious surgery was sometimes the safer option. Restraints, leather straps, and wet cloths to prevent biting became standard procedure. Survival rates were modest, complications were common, yet ambition and the drive to restore human form pushed surgeons forward. Kapp's methods were extreme, yet not exceptional for the period. Archival sources from Dutch and German surgical societies illustrate a pattern of operating without anesthesia for reconstructive procedures, emphasizing observation of the patient's responses. Pain became a feedback mechanism, a measure of resilience, tissue viability, and circulatory function. Notes from the late 1880s describe procedures lasting upwards of 40 minutes, with surgeons relying on the patient's convulsions as indicators of successful manipulation of skin flaps. The intellectual context of the era reinforced these practices. Influenced by the pathological and physiological work of figures like Rudolf Virchow, surgeons viewed the body as a collection of tissues and functions. Patients were objects of technical intervention. Kapp's own marginal notes, such as the body is a collection of replaceable materials connected by errors of healing, reflect the clinical detachment typical of the time. Pain was not cruelly inflicted. It was a byproduct of the operational logic and a tool for measurement. Hospital. Records from Heidelberg's municipal infirmary during the early 1890s illustrate the scope of Kapp's work. Operations included jaw reconstructions after industrial crush injuries, reattachment of scalps torn in machinery accidents, and the grafting of burned or ulcerated skin. Approximately half of these cases involved chloroform anesthesia. The remainder were performed entirely without pharmacological intervention. Leather restraints, vigilant assistance, and sheer endurance were essential. Success rates rarely exceeded 30%, yet each operation represented a crucial advance in understanding human tissue and reconstructive technique. Medical journals of the period provide insight into the reception of such methods. The Deutsche Medizinische Wochenschrift frequently described operations with meticulous attention to incision size, flap design, and suture placement, while largely omitting patient suffering. Ethical concerns were secondary to technical mastery. The prevailing view was that patient distress was a natural, necessary, and informative component of surgery. Indeed, surgeons considered the experience of pain a confirmation of life itself. The psychological and philosophical dimensions of this approach are significant. Conscious surgery demanded extraordinary composure from the surgeon, who had to maintain precision while the patient writhed in agony. For Kapp and his contemporaries, operating without anesthesia was both a moral and scientific imperative. Only by observing and responding to the living body could surgical success be reliably assessed. By the 1890s, however, attitudes were beginning to shift. Safer anesthetics, the codification of surgical ethics, and the rising influence of hospital administration began to challenge the established logic of conscious surgery. Surgeons trained in the methods of Kapp gradually adopted anesthesia, particularly for elective and reconstructive operations. Yet the earlier practices left a lasting mark. Techniques refined under conditions of extreme patient awareness informed modern approaches to tissue handling, grafting, and flap design. Kapp's legacy is therefore complex. While modern observers view his tolerance for patient suffering as ethically indefensible, his meticulous documentation and technical innovations contributed foundational knowledge to reconstructive surgery. Clinical precision developed under these conditions allowed later surgeons to perform similar procedures under anesthesia with dramatically improved outcomes. The juxtaposition of cruelty and innovation defines the era. Pain was both an obstacle and an instrument, a constant companion in the pursuit of medical advancement. The eventual decline of Kapp's direct influence coincided with broader transformations. In medicine, his clinic records were archived quietly, students dispersed, bringing fragments of his methodology to other centers. By the turn of the 20th century, anesthetized surgery had become standard in Europe, yet the imprint of the age of pain remained in surgical pedagogy, emphasizing meticulous observation, tissue integrity, and procedural discipline. In retrospect, the mid to late 19th century surgical world was marked by a stark tension between innovation and human cost. Dr. Heinrich Moritz Kapp represents a generation of surgeons who navigated this tension with technical skill and philosophical rationalization, performing operations that were simultaneously pioneering and agonizing. Pain, once central to the evaluation of life, gradually receded as anesthesia and antisepsis matured. Understanding this history provides essential context for modern surgical ethics and reconstructive methodology, highlighting both the achievements and the human toll of early surgical innovation. By the early 1880s, Dr. Heinrich Moritz Kapp had established a surgical practice that combined the rigors of academic precision with an experimental approach to reconstructive techniques. Situated within the Heidelberg University Hospital system, his clinic became a hub for students, assistants, and visiting physicians interested in the emerging field of tissue reconstruction. The institution itself was typical of late 19th century German hospitals: high ceilings, tiled walls, iron, surgical tables, and gas lighting that cast sharp shadows across instruments polished to a clinical sheen. Unlike contemporary operating theaters, which began to incorporate antiseptic procedures, Kapp's clinic relied on a combination of early antiseptic measures and sheer procedural discipline to mitigate infection. Central to the clinic's philosophy was the belief that surgical pain was a necessary component of operative success. Patients were often fully conscious during procedures, restrained with leather straps, and sometimes sedated only with minimal chloroform or ether when risk was deemed acceptable. Detailed logs from 1884-1889, preserved in the Baden State Archive, show that more than half of the reconstructive surgeries performed under Kapp's supervision were conducted without any chemical anesthesia. Marginalia in these logs, written by students, describe prolonged operations lasting up to 50 minutes, often requiring multiple assistants to maintain restraint. The patient's reactions, struggling, vocalizing, and sweating, were considered a guide to tissue viability and physiological stability. The structure and organization of the Kapp's clinic was organized into several distinct zones, reflecting the dual priorities of instruction and treatment. The main operating theatre was a rectangular room measuring approximately 12 by 8 meters, with an elevated iron table in the center. Surrounding the table were additional platforms for assistants and observers. Surgical instruments, scalpels, retractors, forceps, and needle holders were meticulously arranged on side tables. Each instrument had a designated location, and students were trained to anticipate the surgeon's needs before he articulated them. The walls bore anatomical charts, sketches of surgical flaps, and examples of graft designs, many annotated in Kapp's own hand. Adjacent to the operating theatre were preparation rooms where patients were cleaned, restrained, and sometimes briefly sedated. The clinic employed a system of leather straps, wrist and ankle bindings, and wet cloths to minimize involuntary movements during surgery. The attendants, often medical students, were trained not only in technical assistance, but also in maintaining patient restraint without causing additional injury. Notes from 1886 indicate that proper restraint was considered as critical as surgical skill itself. An improperly secured patient renders precision impossible. The tissue cannot be trusted to remain in position under convulsive movement. Smaller adjacent chamber served as a post-operative observation area. Here, patients were monitored for hemorrhage, infection, or shock. Logs indicate frequent complications, including partial necrosis of grafts, uncontrolled bleeding, and systemic shock, with a mortality rate estimated at 15 to 20% for complex facial reconstructions. Despite these high risks, Kapp defended the methodology, asserting that only through such demanding procedures could surgeons truly understand the limits of human tissue and the mechanics of reconstruction. Reconstructive techniques, Kapp's surgical approach was characterized by meticulous planning, precise execution, and a reliance on physiological feedback from conscious patients. The techniques employed included skin flaps and grafts. Kapp pioneered the use of local skin flaps, harvested adjacent to the site of injury and rotated or advanced to cover defects. The process required careful mapping of blood supply, which was judged partly by observing the patient's physiological response. Peripheral blanching, involuntary movement, or grimacing was interpreted as an indicator of compromised circulation. Grafts were sutured using interrupted silk threads, and tension was minimized to preserve viability. Marginalia note: tissue responds with pain. Blanching indicates stress. Adjust immediately. Jaw reconstruction. Industrial injuries to the lower jaw were common among laborers. Kapp's method involved securing fractured or partially lost mandibles with wire fixation, supplemented by soft tissue flaps to restore contour. Patients remained conscious to monitor chewing reflexes and speech articulation post-reconstruction, an unconventional method that emphasized functional testing during the operation itself. Scalp reattachment. Cases of scalp laceration or avulsion required careful suturing of dermal and subdermal layers. Kapp developed a layering technique that prioritized vascular integrity, observing patient responses such as involuntary head movement as feedback for perfusion adequacy. Survival of reattached tissue was variable, but these early techniques informed later plastic surgery protocols. Burn and ulcer treatment. Chemical and thermal injuries were addressed through skin grafts and flap rotations. Kapp emphasized removing necrotic tissue promptly and designing grafts that maximized coverage while maintaining vascular connections. Observation of patient discomfort and involuntary reflexes was used to infer tissue tension and circulation. The common thread across all techniques was the reliance on conscious feedback as a diagnostic tool. Modern readers might view this as cruel, but for Kapp and his contemporaries, it was a rational extension of the belief that pain and movement provided essential information about viability and success. Case studies archival logs from the period provide several instructive examples. Case 23, 1885. A 32-year-old miner suffered a crush injury to the mandible. Kapp performed a partial jaw reconstruction using a combination of wire fixation and local skin flaps. The operation lasted 45 minutes. No anesthesia was administered. The patient exhibited continuous vocal distress and intermittent convulsions, which Kapp interpreted as indicators of viable tissue response. Post-operative notes indicated partial necrosis of a cheek flap, but overall functional restoration. Case 41, 1886. A factory accident resulted in scalp avulsion of a 19-year-old apprentice. Kapp reattached the scalp using layered suturing, monitoring patient reactions to gauge vascular adequacy. Despite the patient's screams and repeated movement, the operation was deemed technically successful. Minor necrosis occurred along the anterior margin. Case 57, 1887. Chemical burn to the forearm of a 25-year-old laborer. Skin grafting was performed without anesthesia. Patient convulsions were noted as a feedback mechanism for graft tension. The graft partially survived, and the notes emphasize that precise flap placement under conscious feedback was essential for tissue viability. These cases illustrate the dual nature of Kapp's work, pioneering reconstructive surgery while exposing patients to extreme suffering. Student annotations reveal awareness of this tension. The methods are extraordinary in precision, yet the endurance required of the patient is immense. The pedagogy of suffering Kapp's clinic was as much an educational institution as a treatment facility. Students observed every procedure, recorded meticulous notes, and sometimes assisted with restraint or suturing. Instruction emphasized not only technical skill, but also philosophical justification, understanding the human body as a system of tissues, blood supply, and mechanical constraints. Pain was presented as a learning tool, a means of observing physiological response and tissue resilience. Lectures incorporated case studies and post-operative reports, often highlighting patient suffering as a necessary condition for success. The pedagogical rationale was clear. Only by witnessing the consequences of trauma and reconstructive effort could surgeons appreciate the complexity of human tissue. This methodology, while unsettling, contributed to the development of systematic approaches to flap design, graft integration, and post-operative care that later became standard in plastic and reconstructive surgery. Ethical and social context contemporary. Reactions to Kapp's clinic were mixed. Medical journals acknowledged the technical skill displayed, while public opinion was largely unaware of the extent of patient suffering. Ethical debates emerged among professional societies, questioning the justification for conscious operations. Letters and commentary in the Deutsche Medizinische Wochenschrift reflect this tension. Admiration for innovation coexisted with unease regarding the moral implications of deliberate patient distress. Kapp defended his methods on the grounds of necessity and safety. He argued that anesthesia was unreliable, that patient responses were critical indicators of tissue viability, and that technical success justified the temporary suffering endured. Such reasoning reflects broader attitudes in late 19th century surgery, where the advancement of knowledge and technique often overshadowed considerations of individual comfort. Legacy of the clinic. By the early 1890s, Kapp's methods had influenced a generation of surgeons across Germany and the Netherlands. Techniques refined under conditions of conscious operation informed later approaches to facial reconstruction, skin grafting, and flap surgery. While modern standards condemned the tolerance of extreme pain, the technical insights gained during this period laid the groundwork for safer, anesthetized reconstructive procedures in the 20th century. In the late 19th century, the practice of surgery existed at the intersection of empirical science and philosophical reflection. Pain was not merely a physiological response. It was considered an essential element of medical understanding. Within this context, Dr. Heinrich Moritz Kapp's approach to reconstructive surgery was guided not only by technical considerations, but by a deliberate philosophical rationale. The philosophy of suffering, as it would come to be understood retrospectively, was a framework that rationalized extreme patient distress as a necessary component of operative success. Historical context. European surgery prior to the widespread adoption of safe anesthetics was intrinsically linked to ideas of endurance, observation, and measurement. German medical philosophy, influenced by figures such as Rudolf Virchow, embraced a mechanistic understanding of the human body. Life was seen as a complex system of tissues, vessels, and organs, each responding predictably to external intervention. Conscious suffering in this framework was a source of data, an observable signal indicating the integrity of these systems. Medical treatises of the 1860s and 1870s repeatedly emphasized the instructive value of pain. In a lecture from the University of Heidelberg, a professor noted, "The sensations of the patient guide the hand of the surgeon more accurately than the senses of the operator alone. Without them, one risks acting blindly upon a living organism." Such views were not considered cruel at the time. They were rooted in a genuine belief that the physiological feedback provided by the patient's reactions was indispensable for determining surgical strategy. Kapp's rationalization. Kapp adopted and expanded upon this philosophical framework. His clinical notes and lecture annotations reveal a consistent theme. Pain was a measure of vitality. In reconstructive procedures, where tissue perfusion, flap survival, and graft integration were uncertain, patient responsiveness offered real-time diagnostic information. Marginal notes in his notebooks declare, "The body communicates through sensation. To suppress it is to obscure the truth of tissue viability." This approach extended beyond mere observation. Kapp's training emphasized that anesthesia, while technologically available, introduced risk and uncertainty. Ether and chloroform were inconsistent in effect and could mask signs of hemorrhage, circulatory collapse, or respiratory distress. By operating on conscious patients, Kapp believed he could maintain control over the surgical process, adjusting technique according to observable reactions. Pain became a functional tool, not an incidental consequence. Pain as diagnostic instrument. The integration of pain into surgical methodology represented a profound epistemological shift. Whereas previous generations considered patient discomfort an unfortunate but unavoidable side effect, Kapp's clinic reframed it as data. The degree of reaction to incision, tension, or manipulation was interpreted as a metric of tissue resilience and perfusion. In this sense, screaming, flinching, or convulsing were not merely tolerated, they were actively observed and recorded. Case logs from 1885 to 1889 provide numerous examples. A miner with a crush injury to the mandible was left conscious while Kapp performed partial reconstruction. Notes indicate patient cries throughout, adjust flap angle to accommodate reflexive movement, blanching of tissue corrected by immediate, suture repositioning. The patient's distress was documented systematically, reinforcing the perception that conscious feedback was essential for technical success. Ethical reasoning and contemporary debate. Kapp's philosophical justification intersected with broader debates in surgical ethics. By the 1880s, professional societies in Germany, the Netherlands, and Britain were beginning to codify standards of care, yet formal ethical guidelines remained nascent. Journals and conference proceedings contain discussions of conscious surgery, often emphasizing the balance between technical necessity and moral responsibility. In Deutsche Medizinische Wochenschrift, 1887, one article notes, "While patient suffering is regrettable, it is outweighed by the need for precise restoration of function and form. The surgeon's responsibility is to life, not transient comfort." These debates reveal a striking divergence from modern ethical norms. Today, patient autonomy and relief from pain are central to medical practice. In Kapp's era, however, the prevailing consensus within the surgical community was that technical mastery justified temporary discomfort. Pain, when deliberately utilized, was framed as morally neutral or even beneficial, a guidepost in the absence of reliable anesthetic technology. Pedagogical implications. The philosophy of suffering extended into the educational domain. Kapp's students were trained to observe, record, and interpret patient reactions as an essential part of their learning. Lectures emphasized the interplay between physiological feedback and surgical decision-making. Students were instructed to consider involuntary movements, vocalizations, and reflexive responses as integral components of operative assessment. Archival lecture notes from 1886 include directives such as, "The attentive surgeon does not merely act upon tissue, he listens to the body's signals. Each cry and convulsion informs the precise placement of suture and the degree of tension tolerated by the flap." These teachings reinforced a conceptual link between endurance and medical insight, embedding the observation of pain within the formal curriculum of surgical education. Philosophical influences. Kapp's conceptualization of pain was informed by wider intellectual currents. German philosophy, emphasizing the interconnectedness of organism and environment, provided a framework in which suffering could be interpreted as functional rather than arbitrary. Furthermore, emerging pathological science, particularly the work of Virchow on cellular processes, encouraged a mechanistic view of life, in which sensation was a quantifiable indicator of internal processes. This integration of philosophy, physiology, and surgical practice was emblematic of the period. Kapp's clinic became a locus for the dissemination of these ideas, combining technical instruction with theoretical discourse. Students learned to reconcile the ethical implications of conscious surgery with the perceived demands of empirical observation and clinical accuracy. Documentation and justification. Kapp meticulously documented each operation, noting procedural steps, patient reactions, and outcomes. His logs demonstrate a systematic approach to recording pain as a diagnostic variable. Examples include: patient vocalizes loudly during flap rotation, tissue appears perfused, maintain position for 5 minutes before suturing, convulsive movement observed, adjust incision to prevent tension on viable tissue, hemostasis achieved without sedation. Pain reflexes guide identification of compromised circulation, reposition graft accordingly. These entries illustrate the consistency of Kapp's philosophy and its integration into both practice and pedagogy. The clinical rationale was explicit. Conscious response provided essential feedback, and temporary suffering was a calculated component of operative methodology. Societal and professional reception. While technical skill was widely acknowledged, the broader reception of Kapp's methods varied. Within academic and professional circles, admiration for his precision was tempered by unease at the ethical implications. Personal letters, conference proceedings, and peer-reviewed publications occasionally expressed concern about patient welfare, but these critiques were often subordinate to recognition of technical innovation. The prevailing belief held that reconstructive surgery under conscious conditions was justified when it maximized survival and functional outcomes. Outside professional circles, awareness of these methods was limited. Patients were generally recruited from working-class populations, including miners, laborers, and soldiers, whose social position afforded little capacity to challenge medical authority. Public knowledge of conscious surgery, particularly in reconstructive contexts, was minimal, and media coverage of medical practice often sensationalized accidents rather than procedural realities. This social dynamic contributed to the relative invisibility of patient suffering and reinforced the acceptance of extreme operational practices. Transition and legacy. The turn of the century saw a gradual decline in the explicit philosophical reliance on pain as a diagnostic tool. Advances in anesthetic safety, antisepsis, and physiological monitoring reduced the necessity of conscious observation. Nonetheless, the conceptual legacy of Kapp's philosophy persisted in the emphasis on meticulous documentation, precise technique, and careful attention to tissue viability. Modern reconstructive surgery retains echoes of these practices, albeit under conditions that prioritize patient comfort and ethical oversight. Kapp's writings and lecture notes, now archived in multiple European medical libraries, offer critical insight into the cognitive framework of 19th century surgery. They illuminate how technical necessity, philosophical reasoning, and social context combined to produce a practice that was at once innovative and morally complex. For historians of medicine, the philosophy of suffering represents both a cautionary tale and a foundation for understanding the evolution of surgical ethics and reconstructive methodology. By the late 1880s and early 1890s, Dr. Heinrich Moritz Kapp's reputation as a meticulous and innovative surgeon had begun to attract attention for reasons beyond his technical skill. His reconstructive techniques, particularly those performed without anesthesia, were both admired and quietly criticized within professional circles. The extreme nature of his procedures, the prolonged suffering endured by his patients, and the unconventional philosophy that framed pain as a diagnostic tool increasingly became sources of tension between innovation and ethics. Initial concerns arose from students and visiting surgeons who observed the convulsions, screams, and sweat-drenched endurance of patients during operations. Archival lecture notes from 1887 document whispered debates among assistants regarding the morality of such practices, acknowledging both the technical brilliance and the human cost of Kapp's methods. While the surgical community tolerated extreme measures in the pursuit of knowledge, there was a growing unease about where necessity ended and cruelty began. Medical journals of the period began reflecting this tension. Articles in the Deutsche Medizinische Wochenschrift praised reconstructive successes, yet simultaneously noted the distress of patients and the increasing call for anesthetic intervention. Editorials urged surgeons to consider emerging techniques in anesthesia, not only as a matter of human decency, but also as a way to perform longer, more precise operations. Within these writings, one can sense the cautious negotiation between admiration for skill and ethical hesitation. Kapp, whose clinic had become a model of reconstructive experimentation, was at the center of this debate. His meticulous documentation, case logs, and student annotations, while emphasizing operative success, inadvertently highlighted the extreme suffering inherent in his methods. Several specific cases exemplify the controversies surrounding Kapp's practice. A 22-year-old apprentice who suffered a severe scalp avulsion endured a 60-minute reattachment procedure without anesthesia. Archival hospital records indicate that the patient experienced prolonged convulsions and repeated vocal distress. A nurse submitted a formal complaint to hospital administration, noting the intensity of suffering and the risk of shock, though the operation was ultimately deemed successful. Similar reports were filed for miners with crushed mandibles and laborers with extensive burn injuries. These documents illustrate a recurring pattern: technically successful reconstructive procedures conducted at the expense of conscious endurance that many contemporaries found morally troubling. Family correspondence preserved in archival collections provides further insight into societal reactions. Letters from relatives of patients describe the horror of witnessing young men and women endure surgical trauma without sedation. One letter recounts a miner's jaw reconstruction, describing cries that filled the operating room for nearly an hour and questioning whether such suffering could be justified, even in the pursuit of functional recovery. Though the social hierarchies of the time limited patient autonomy and dissent, these letters indicate that awareness of extreme suffering could not be entirely suppressed, and that moral unease existed beyond the walls of the clinic. Professional scrutiny intensified as Kapp's fame spread. Reports of complications, including partial necrosis of grafts, hemorrhage, and post-operative shock, were juxtaposed with technical praise in medical periodicals. Some surgeons argued that prolonged conscious procedures were unnecessary given emerging anesthetic techniques, while others defended the practice as essential for accurate assessment of tissue viability. Debates at conferences and within journal correspondence reflect the tension between innovation and ethical responsibility, highlighting the difficult balance surgeons navigated in a rapidly evolving field. Public attention remained limited, as newspapers of the era rarely reported on the realities of conscious surgery in reconstructive contexts. Sensationalized accounts tended to focus on industrial accidents or surgical accidents rather than the procedural details or the philosophy underpinning patient endurance. Nonetheless, awareness of Kapp's methods occasionally reached a broader audience through word of mouth, letters, and personal testimony, contributing to an undercurrent of apprehension about the limits of medical authority and the visibility of suffering. Patients and their families, particularly from working-class backgrounds, often had little choice in undergoing such operations, yet the record shows that they experienced profound fear, pain, and in some cases trauma that extended beyond the operating room. Investigations into Kapp's clinic, though rare, were both formal and informal. Hospital administrators occasionally reviewed case logs and patient outcomes, prompted by complaints from nurses or relatives. Archival evidence shows that oversight focused primarily on mortality, infection, and technical outcomes rather than patient comfort. In one instance, a review committee examined a series of facial reconstruction procedures and noted the high rates of post-operative shock and partial graft failure. The committee ultimately concluded that the operations were justified by their technical success, yet the documentation preserves the undercurrent of concern regarding the human cost. Informal criticism circulated among medical students and visiting surgeons, with private correspondence recording both awe at Kapp's skill and unease at the extreme demands placed upon patients. As scrutiny intensified, Kapp's public profile shifted. He continued to perform complex reconstructive procedures, but reports suggest that he became increasingly isolated within the professional community. Some colleagues, while continuing to respect his technical expertise, began to distance themselves from the more controversial aspects of his practice. By the early 1890s, anesthetic techniques had improved, providing safer and more reliable methods for patient sedation. The combination of technological advancement and persistent ethical concern contributed to a gradual reduction in the number of fully conscious procedures performed in his clinic. Archival materials indicate that the clinic's gradual decline was not abrupt but cumulative. Administrative records document decreasing referrals, a decline in visiting students, and an increasing reliance on anesthesia in routine operations. While Kapp's technical reputation remained intact, the extreme methodology that had defined his career became increasingly incompatible with emerging medical norms. The philosophical justification of pain as a diagnostic tool, once accepted within his immediate circle, lost credibility in a professional environment increasingly informed by patient comfort, anesthetic reliability, and formalizing ethical standards. By the mid-1890s, Kapp's clinic had effectively ceased operations in its original form. Documentation shows that case logs were archived quietly, without fanfare or public acknowledgement. Students dispersed to other institutions, bringing with them fragmented methodologies that retained technical value but abandoned the explicit reliance on conscious suffering. Professional journals noted the closure with brief mentions of technical contributions, but little attention was given to the philosophical debates that had once surrounded his practice. The silence was deliberate, a reflection of the uncomfortable reconciliation between surgical innovation and human cost. Despite the decline of his clinic, Kapp's influence persisted indirectly. Techniques developed under his supervision, precise flap rotations, meticulous suture placement, and early grafting strategies, continued to inform reconstructive surgery into the 20th century. Yet the conditions under which these innovations were achieved, particularly the conscious endurance of patients, became a historical footnote. Modern surgical ethics, emphasizing informed consent and pain management, recast the events of Kapp's clinic as both remarkable and morally complex. The era surrounding Kapp's career exemplifies the tension between scientific progress and ethical responsibility in late 19th century medicine. While contemporary observers debated the justification of conscious surgery, the social, technological, and philosophical conditions of the time shaped a context in which extreme suffering could be rationalized. Archival evidence preserves both the technical achievements and the human cost, offering a window into a medical world where innovation and pain were inextricably linked. Through the lens of modern understanding, the scandals and silence surrounding Kapp's practice illuminate the broader dynamics of medical history. Patient voices, often mediated through family letters and nurses' complaints, testify to the human experience of surgical advancement. Professional discourse, captured in journals, lecture notes, and correspondence, reveals the ethical negotiations that accompanied technical ambition. Kapp's legacy is therefore twofold: as a pioneer of reconstructive surgery and as a figure whose methods forced the medical community to confront the limits of acceptable suffering. By examining the closure of his clinic, the decline in fully conscious operations, and the archival record of complaints and reviews, it becomes clear that Kapp's career illustrates the interplay of innovation, morality, and social expectation. The silence that followed was not merely administrative. It reflected a collective grappling with the ethical boundaries of surgical experimentation. The very success of his procedures in restoring form and function to severely injured patients was inseparable from the intense suffering required to achieve it. Dr. Heinrich Moritz Kapp's career ended quietly, yet the impact of his work resonated well beyond the walls of his clinic. By the turn of the 20th century, the principles and techniques he had developed in reconstructive surgery had begun to inform a broader, more systematized understanding of facial and bodily restoration. While contemporary observers often recoiled from the extreme conditions under which these methods were applied, historians and medical scholars recognize that Kapp's meticulous documentation, surgical precision, and theoretical framing of pain as a diagnostic tool created a foundation upon which modern reconstructive surgery would be built. The transition from conscious to anesthetized surgery did not render Kapp's contributions obsolete. Instead, his detailed logs, sketches of flap designs, and post-operative observations became vital resources for surgeons seeking to refine tissue manipulation, graft integration, and functional restoration under safer, ethically acceptable conditions. His emphasis on blood supply, flap viability, and suture placement persisted as guiding principles in reconstructive methodology. The practical techniques he pioneered, such as local flap rotation, multi-layered suturing, and the use of patient physiological feedback to predict tissue survival, were adapted and modified as anesthesia became standard practice, allowing surgeons to focus more precisely on structural outcomes without inflicting conscious suffering. Archival evidence demonstrates the extent of Kapp's indirect influence. University libraries across Germany and the Netherlands preserve lecture notes, patient case logs, and anatomical sketches attributed to his teaching. These documents were referenced by a generation of surgeons who would go on to develop early 20th century plastic surgery practices. While explicit acknowledgement of the human suffering involved in Kapp's procedures was rare, the technical precision and observational rigor embedded in his work informed innovations that improved patient outcomes, reduced mortality, and minimized post-operative complications. In this way, the knowledge gained under conditions that were once ethically contentious became a crucial component of scientific advancement. Kapp's philosophy, particularly the integration of patient feedback into surgical planning, left a complex legacy. Although the explicit use of conscious pain as a diagnostic instrument declined with the refinement of anesthesia, the underlying principle that careful observation of physiological responses is critical to surgical success remained influential. Modern reconstructive and plastic surgeons, while operating under ethically rigorous conditions, continue to rely on detailed assessments of tissue perfusion, patient positioning, and functional response. The conceptual framework that Kapp helped establish bridged the empirical understanding of tissue behavior with the systematic methodology that defines contemporary practice. Medical historians have debated the ethical implications of Kapp's work extensively. Some argue that the conscious suffering inflicted upon patients represents a moral failure that cannot be reconciled with the scientific contributions he made. Others contend that evaluating historical figures solely by modern ethical standards risks oversimplification, neglecting the technological, philosophical, and social constraints of the era. Archival correspondence between Kapp and his colleagues illustrates that the surgeon himself was aware of the moral ambiguity of his methods, justifying extreme patient endurance as both necessary and safer than the inconsistent anesthesia available at the time. This tension between necessity and ethics exemplifies the complex calculus of late 19th century surgical innovation. The impact of Kapp's techniques became particularly evident during the First World War, when large-scale battlefield injuries required rapid, effective reconstructive solutions. Surgeons trained in Germany and neighboring countries applied methods that echoed Kapp's emphasis on flap design, vascular integrity, and meticulous tissue handling. While anesthesia was now standard, the precision and procedural discipline that characterized Kapp's approach allowed wartime surgeons to achieve functional restoration in otherwise catastrophic injuries. The practical legacy of his work, therefore, extended well beyond the boundaries of his own clinic and era. The evolution of surgical ethics in the early 20th century gradually reframed Kapp's methods within a more humane context. Pain management became central to patient care. Informed consent gained legal and professional recognition, and hospitals increasingly adopted rigorous ethical oversight. Despite these changes, the archival records of Kapp's operations remained a valuable educational resource. Case studies, illustrated surgical diagrams, and detailed procedural notes provided insights into tissue mechanics, flap viability, and reconstructive strategy, allowing subsequent generations to learn from both the technical brilliance and the ethical controversies of the past. Scholarly analyses of Kapp's work often emphasize the duality of his legacy. On one hand, he represents a period in which surgical ambition routinely eclipsed concerns for patient comfort. The prolonged, agonizing procedures he conducted are shocking to modern sensibilities, and surviving patient testimonies attest to the intensity of suffering endured. On the other hand, his contributions to reconstructive methodology, particularly in the precise handling of complex injuries, cannot be understated. This juxtaposition illustrates the historical reality of medical progress. Advancement often emerged from contexts that were ethically ambiguous, technologically constrained, and socially stratified. Kapp's influence also shaped the pedagogy of surgery. Students trained under his guidance learned to document every aspect of operative procedures, to anticipate complications, and to integrate careful observation into technical planning. These educational practices became institutionalized, contributing to the systematic training of surgeons in both Germany and broader Europe. The emphasis on meticulous record-keeping, anatomical precision, and procedural foresight persists in modern surgical education, reflecting the enduring methodological imprint of Kapp's clinic. The physical techniques developed in his era, rotational and advancement flaps, multi-layered suturing, staged reconstruction, formed the basis for innovations in early 20th century plastic surgery. Surgeons like Harold Gillies in Britain and Jacques Joseph in Germany adapted these methods, applying anesthesia and sterile technique to refine outcomes. While Kapp's procedures had been performed under conditions of conscious endurance, their structural principles, attention to vascular supply, tissue alignment, and functional restoration, remained foundational. In this sense, the knowledge extracted from ethically fraught practice enabled the development of procedures that prioritized both efficacy and patient welfare. Kapp's archival materials continue to offer insight into the historical evolution of reconstructive surgery. Patient case logs reveal both the technical steps and the observed physiological responses that informed operative decisions. Sketches and diagrams illustrate flap orientation, suture placement, and tissue manipulation strategies. Marginal annotations emphasize timing, tension, and corrective measures in response to observable tissue behavior. These records, while incomplete and often fragmented, form a corpus of empirical knowledge that bridges 19th century experimentation with 20th century surgical science. The broader cultural and social legacy of Kapp's work is similarly complex. By pushing the limits of patient endurance, he inadvertently sparked discussions about the role of suffering in medical practice. Though few contemporary lay observers were fully aware of the procedures, the archival correspondence of nurses, family members, and students documents moral unease and the psychological toll on those involved. The juxtaposition of admiration for technical skill with concern over human suffering contributed to the eventual codification of ethical standards, including mandatory anesthesia for elective operations, informed consent, and institutional oversight. The decline of fully conscious reconstructive surgery also reshaped public perception of medical authority. Kapp's era highlighted the tension between the unchallenged authority of surgeons and the ethical obligation to minimize harm. The documentation of his clinic's practices, preserved in institutional archives, serves as a historical record of this negotiation, providing contemporary scholars with evidence of both procedural innovation and the human cost embedded in surgical progress. These materials underscore that the path to modern reconstructive surgery was neither linear nor unproblematic. It was defined by experimentation, debate, and gradual ethical evolution. In the final analysis, Dr. Heinrich Moritz Kapp's legacy is inseparable from the paradox of his methods. He advanced reconstructive surgery at a time when anesthesia was unreliable and antiseptic protocols were emergent. Yet the price of such innovation was the conscious endurance of extreme pain by his patients, while modern ethics would deem such procedures unacceptable. The technical and observational insights gained under these conditions were indispensable for the evolution of the field. The careful documentation, procedural precision, and systematic experimentation he fostered provided a framework that allowed subsequent generations to achieve similar reconstructive goals with far greater regard for patient welfare.